maybe do a better job than I do. But Dr. Urso is a eye surgeon, ophthalmologist, was head of ocular oncology at MD Anderson, which is one of the major cancer centers in the world. He is also head of eye trauma at Hermann, right?
Yeah, for about 14 years.
Yeah, Herman's like the Gunslinger Club. It's like the big trauma center in Houston. I used to live up around there, so that's trauma central there, Hermann Hospital.
Yeah, that's the real deal.
And Dr. Urso, I know he's been doing a carnivore diet, carnivore-ish diet for a couple of years now. I know we've been kind of going back and forth on social media for a while. And I apologize for not having you on stuff earlier. I've meant to do that, but it just kind of,
I'm glad to be here.
But and then you've also had some pretty interesting insight and thoughts about this whole coronavirus sort of situation. And so I want to just, so just so you know, we'll have a whole bunch of people in here, and we're going to entertain some questions as they come up. But first, we'll get into some introductory material. Can you give me maybe a little more background on yourself that I haven't already introduced, so we can kind of get going? I don't know if you froze.
My original background is I did some drug development. And can you hear me on there? It says my connection's unstable. Okay.
We can hear you. Yeah.
So I developed a drug that actually made it all the way through FDA testing called Oxervate. It's good for wounds on the eye. It's good for actually diabetic wounds. It's not approved for that yet, but I also have like 3 other already approved drugs that I'm got off-label uses for that I'm working on, and one of them being azithromycin that I've been using for like 20 years for a scarring disorder on the eye. It's amazingly down-regulates the immunomodulatory cytokines. It's really awesome for it. And I have a disease that has a high recurrence rate, and I haven't had a recurrence in like 20 years. So I spent a lot of time thinking about the azithromycin. The hydroxychloroquine, as an ophthalmologist, I end up seeing about in my career, probably 5,000 patients on hydroxychloroquine. We look for toxicity. So I've had a lot of experience with that. So a lot of the products that are being touted right now, I actually have a pretty intimate exposure to. And as I said, the drug development background, has helped me to kind of, peel through this material. I feel like I can add something in and basically sort of say, hey, this insanity, as Ioannidis said, the guy, the stats guy from Stanford, it's based on epically poor data, and we're making draconian measures, on data that's not that great. So, I mean, I'm glad to get on here and kind of talk about the options. I feel like I can add a lot to what's been said out there, and I think the guys that are out there that have the Fauci and guys like that are out there that can say these things seem to be reluctant to just put it out there. I don't understand it. I don't know the backstory. I just know it seems like silliness to me.
Yeah, I mean, let's and you're talking about this coronavirus lockdown, the social distancing, the shutting down almost the entire economy. And I saw Trump just recently announced that he intends to reopen things within a couple of weeks. At least that's his current thoughts. And he says he feels that the economic damage and the loss of life and health and livelihood will be worse due to the economic shutdown than anything the virus potentially could do. And so it's kind of a tough position to be in. One of the, I know you kind of relayed something to me that the Ophthalmology Association sent out saying, hey, we're going to shut down all non-essential. What was the story on that? And what's been the resolution on that?
Yeah, so basically they basically used the tactic of, hey, we're gonna go forward and we're gonna help you guys. You guys aren't really doctors. Stay home. Don't waste resources. Now I shot back to him and said, I'm a doctor first and ophthalmologist second. But basically what has happened is we just got a notice today from one of the top anesthesiologists in the state that they're looking that if people are doing what's called non-essential surgery, like I have a DCR this week, I have an infected tear gland and it's pretty infected. I'm afraid to do it because half those surgeries are not infected, and they've asked people to report back to the state with actual potential imprisonment for doing these surgeries. So that notice came out to me today. And so I saw somebody commented on draconian measures. They're draconian. they are. I mean, they're basically telling us we got to stay in our houses. You're going to be arrested if you're out on the street. It is what it is. I consider that draconian. And I'll tell you this, I'm scared to do the surgery. I'm probably going to cancel it, even though she needs it.
Yeah, I mean that is scary. And you're in Texas, and Texas is definitely a place where you think there's more sanity. In some of the other places. I'm in California, which it doesn't surprise me. I wouldn't be surprised if we have National Guard, walking down the street telling you don't come out of your house. We've got people that are saying don't even go outside, which I think is just absolutely insane. You can certainly go outside and not mingle with people, which I think is just kind of crazy. And there's people that literally believe that they need to be locked down in the police. We need to be under a police state to enforce this stuff. But let's, because we're getting mixed messages. There's people out there like, people gloom and doom, and, we need to hide away as long as possible. And then there's other people saying, hey, this is not, it doesn't require what we're doing, and it's hard to make an informed decision on that. So I know you'd sent me some information on Plaquenil or hydrochloroquine or chloroquine, which are old medications have been used for I don't know 50 plus years. I think I don't know how long it's been. Probably even longer than that.
Yeah,
it's shown to have some efficacy, and I've seen a little bit of commentary in the media about that. Is that do you think that's still a viable option for this particular virus?
yeah, I love it for this virus. A couple of reasons. One, we've got great preclinical testing on it. There's a couple of major papers that came out, one in Nature, Journal of Clinical Infectious Diseases, where they basically showed that it had very, very good efficacy against this virus. And I think it's inexpensive and the safety profile is excellent. I've treated 4 patients myself with it and had great success within about 24 to 36 hours, a big turnaround. I saw somebody sent me a video today of a doctor in a large Hasidic Jewish community in New York that had a real big outbreak. And he said that he's treated 300 patients with hydroxychloroquine, Plaquenil, and successfully no one has gone to the hospital. And I think, I think for you and I, it's like, I've said, if our patients came in and they had bronchitis and we said, look, we're going to wait till you get pneumonia before we treat you, people would think that was insanity. And, I look at this the same way. The drug is got a great safety profile. We've got great preclinical stuff. We've even got some studies, the French study that came out. They're non-randomized trials, of course. We've got clinical trials going on here in the country, but we have some non-randomized trials one from China, one from France, where they had success with chloroquine in one instance, but it doesn't make sense to use chloroquine. Hydroxychloroquine, the safety profile is so much better. And the in vitro studies show that it's actually more effective. But so I think it doesn't make any sense for us to have these measures in place when we have an effective treatment. And I'm gonna add something in that I think really was really surprising to me. In January, Fauci put out a paper talking about this, and he saw it coming. And he's our guy that's standing next to President Trump. And he listed out, the fact that this is coming our way, and then he listed out the measures that we can take, which was remdesivir, which won't be available. It's Gilead's drug that'll take like 6 months to ramp up. He mentioned interferon beta, and he mentioned Kaletra. Well, it turns out Kaletra, they put a trial out. It doesn't work in this case. It worked in SARS-2 in 2002. It worked then, but it doesn't work this time. As you know, these things mutate. And basically, he had no mention of chloroquine and hydroxychloroquine. I think he kind of missed the boat on it. And I think in some sense, if you put that paper out, I can't help but think that, to have that paper out there and having the impact that he has and not having any awareness of it, to me, there are studies from 2016 I found that showed that this virus might mutate to animals, from bats to humans, and they showed that this chloroquine and hydroxychloroquine worked. And I think in general, maybe a guy like this maybe should have seen it coming, and he didn't see it coming. Now, I don't know the backstory. I don't get the backstory. I just know we have an effective treatment that's great safety profile, and I don't see why we're not doing it.
Yeah, I mean, I guess it's just, I guess they're going to wait till randomized control trials, and that's going to take I don't know, a month, 6 weeks, something like that. Yeah, something like that to do. So, I mean, it seems that some of these things, we don't have randomized control trials on social distancing. I mean, it's, what we're doing, there are things we're doing. We don't have randomized control trials in closing schools. And there's some thought that kids at home are going to be causing more intergenerational fomite exposure than kids away at school. So if you're at home and you've got grandma living you at the home, or even mom and dad who may be diabetic, I mean, it's one of those things where you just don't know, and people throwing in measures, and we're saying, well, we're going to do this, but we're not going to do that because there's not an RCT. When we see this sort of a bit of panic going on. I know Wendy just commented that in South Africa, they've closed the country till October 16th, and they're rolling out troops to enforce it. So I saw in Denmark, they hurried through legislation that say they're going to make vaccines for this mandatory. They just passed a law that said they could do that. And so, and that opens kind of a slippery slope. I mean, that's a personal choice. And whether you're pro or against vaccines, I mean, I still should be a personal choice for people. And like I said, my kids have been vaccinated. I don't have a general problem with it in general.
Yeah, I'll comment on that if you don't mind. I remember the H1N1, the Guillain-Barré syndrome from the H1N1 vaccine. It's a real thing. And I'm not saying, if you have a good immune system, I'm not a big fan. I personally don't get the pneumovax. I personally don't get the flu vaccine every year just because my immune system, I think, is pretty good. And I'm just, like you said, my kids get vaccines, but I think the number that they actually tout for kids by the time they get to be age 21 is like 69 or something like that. So I think, I sort of pick and choose a little bit. There's a couple, like I did the Hep B vaccine myself because I know I'm going to get stuck sooner or later. So I believe in vaccines, but I think it should be a personal choice in some sense.
Yeah, so I mean, it's scary to see like Denmark. Like I said, they're going to mandate this, and then that opens up, just what else can you mandate? These types of things. And I know there's a lot of conspiracy theories, slippery slopes coming on, and where do we, you put out these draconian things, and then how much of it do you actually roll back? Do you leave some of it in place? Do we have, are we, and this is one of the comments I've made about our healthcare system. We can kind of transition a little bit about, why do we have so much chronic disease? Why is our healthcare system overrun with chronic disease? And now we don't have the capacity to deal with a pandemic or an epidemic without freaking out. And so, we have this save the old people, but keep feeding them cupcakes and crap. No one cares about that, in the bigger scheme of things. And if we were really like, we're going to roll out the troops so no one can go outside, why don't we roll out the troops and stop them from making friggin' Twinkies? I mean, this is the sort of dichotomy that we have here.
And the dichotomy is amazing. Like, where is this line drawn? I guess basically, I would say in some sense, the powers that be, and the medical, there's very few docs that would probably say that a plant-based diet is not a great diet, and it's amazing. We've all been sort of, the propaganda has hit our community tremendously, as you know. And a lot of people that I'm friends with think that this meat-based diet I'm on is terrible. Of course, they look and go, well, it's working great for you. You look pretty good. You're healthy. You're strong. You don't get sick. But I'm worried about my heart. And I'm like, okay, fine. I mean, I like you said, the N=1. The randomized controlled trials haven't been done. It'd be nice as we go forward, because people who are healthier are obviously going to be more resistant to disease. And it's an easy call to say that. People with comorbidities, diabetes, hypertension, they're going to have problems. So
I'm like I said, I'm just kind of figuring, because as an ophthalmologist, I mean, what does the majority of practice look like? Because we've got Dr. Wiedemann here, who's an optometrist, and she sees a lot of diabetic retinopathy, and I'm sure you do too. But I mean, are you doing mostly oncology, or is it more regular ophthalmology now, or how much trauma or oncology there is in the ophthalmology world?
Yeah, well, because I'm in the city where I'm basically the oldest oncologist here, so I get about maybe 4 cases a week, which is 200 a year. It's not a huge number, but considering the what the disease is, I see that's one part of the practice. The other part is like a general ophthalmology practice because we got to keep the doors open. And in general, diabetes, I'd say in Houston, that if you look at our population, at least it feels like over half our population has some low level or even high level diabetes. That's A1Cs running from 6. We are today. I saw only 10 patients. I saw 5 of them had diabetes, and one had a bleed in his eye, and his A1C was 8 point something or other. So, in general, we've got this chronic problem with diabetes that we see a lot of those patients. It's probably only a third of our patients, but that's one of the biggest ones. And I talk to them all the time. Actually, I've sent a lot of my patients your way. I go, you got to Sean Baker, get on his website. Guys got it down. Go listen to him. And a lot of times, I'll tell you what, Sean. One of the things I've seen that's been amazing to me is the difference in C-reactive proteins. So inflammation, when you get on this meat-based diet, inflammation in the body. I had a patient that CRP of 78, and literally within 2 weeks, it came down below 10. So just on an all-meat diet for 2 weeks. So historically, that's only numbers you'd see would be putting them on prednisone. No prednisone, just an all-meat diet. It's made a huge difference in my practice. And at first I had a hard time talking to patients about it because and now I'm about 3 years into it. I think I caught wind of you probably about 6 months after you've been doing it. And I joked around with you. I said, always thought I was the strongest doctor in the country, but clearly I'm not. But I'm trying. So, and I'm 61 and I'm still in pretty good shape. And and my patients, they really trust me a lot. And so historically speaking, I've transitioned a lot of my inflammatory patients over. My thyroid patients, I have a big practice in thyroid because it fits what I do, the external ophthalmic plastic reconstructive background that I have. I was on a cranial-facial team for a while at Hermann for about 12 years. So that side of it, the thyroid and the other inflammatory patients that I see, the tumors, there's a significant number of tumors that are inflammatory in the eye socket, and I get a lot of those biopsy and stuff, and I put them on this diet, and I think I get about half of them to do it, roughly about half, and I'll tell you, as you've made such a difference in so many people's lives, all those testimonials that you've gotten, and I get those to some extent, and I send them all. I said, go to the website, MeatRx, go to justmeat.co. That guy's got a good list of references. Meatheals.com, your Instagram, so it's been helpful to have that out there because what it does is it makes patients feel like, hey, this is okay, it's legit. So if I just tell them in the office and they don't see it anywhere, they're not going to follow through on it because they're like, I can't find anything out here. This doesn't seem legit. So by you taking the lead on this, it's a huge difference for people like me to be able to tell patients, hey, they'll listen to me, but if they don't see anything else out there, they're not going to do it. So by having that platform, it's made a big difference. I can just hand them stuff and say, here, go. This is where you need to go.
Yeah, we certainly appreciate that over here because, like I said, it works when people utilize it, and because a lot of people are asking me in the questions here, just kind of general commentary about, have you seen improvements in eye function, whether vision or reversal of some of the diabetic, retinopathy and stuff?
Absolutely.
In diet.
I definitely have. I mean, it's the retinopathy. Even we've had a couple of patients that I think they've been, like I said, I've got a pretty loyal patient base. They'll listen to me, and the ones I've had reversal on macular degeneration, because a lot of what happens in macular degeneration is driven by like atherosclerosis in a sense, and so I feel like the dietary changes that they make a huge difference in reversing some of those changes that occur. from having a poor diet, all the reactive oxygen species and stuff that are creating that cholesterol, calcium plaques that they have. And so we've been able to see some reversals. We did the calcium scores, CAC scores on some patients. Not a lot. I've probably done about 20, and it's amazing to see over 6 months to see those scores improve. I have one guy, he's improved from like 1,000 something down to like 60 something now over about 2 years. So
Yeah, I mean, and I think there's got Ivor Cummins you may be familiar with. I know I think he's been collecting some of those, and I think they're going to be writing that up. And I know that Dave Feldman and a guy named Spencer Nadolsky are going to be looking at, well, they're going to be doing a study. I think they're going to be doing they're going to be coronary angiograms on these people and see if they can see a reversal with that as well. Because I got Dr. Wiedemann in here. She's an ophthalmologist or optometrist, and she has expressed significant frustration in actually getting people to, actually do it. And you're saying you get about half the people to try it. So how are you convincing people to actually give it a go?
honestly, I got my staff. I got a whole staff that I have a staff that thinks I have superpowers. I think that's one of the things you can do. You got to have a staff that supports you. And I think that helps because they start in on it before I even get in the room, my staff. So have her call me because I actually think because they do a lot of that, they help me prep them. They're in the rooms talking to them. They're showing them the diet. They're talking to them about it. They by the time I get in there, they're already prepped. So they have to hear it more than once. Have her call me and I'll tell her because basically it's a team approach. And then you have to be gentle with most of them because they're older. The propaganda is so strong. You got to be a little gentle the first time. It may take you the second or third visit before you get them to do it. And but you need your team. You got to get a team approach. You've got to have your other staff doing it with you, and that makes a huge difference. So I used to have when I was young in my practice, I didn't have as good of a support staff around me. And so that's the key, I think, is to have that support team around you. And they literally will sit and I'll say, hey, can you go through it with them? And so my staff will sit with them and talk to them for maybe 20 minutes. And, and they'll talk 20 minutes before I get in the room a lot of times. I think that's the key. So yeah, have her call me. I'll help her with it.
Yeah, she's sitting she's on the screen right now. She's right there on the screen. So I've got her muted just because it's trying to get the conversation going. Hey, there are there's a lot of sort of thoughts out there on how to protect yourself from the coronavirus outside of the hand washing and the, not standing next to somebody sneezing and stuff. But we're seeing a lot of things about supplements, zinc, vitamin D, vitamin C, quercetin, all these things. Do we know if there's any real data or efficacy on those things?
A little. John Cannell, the guy at vitamindcouncil.org?
I think so, yeah.
Yeah, he's done a little work on the flu in this. And he found, I think he put a study out showing that in the flu, if you have good vitamin D levels, you're less susceptible to the flu. And that's that's all I focus on. I tell people, say, what do I want to do? I say, number one, make sure your vitamin D levels are good. Most of us are sitting inside. So D is something that a lot of people sitting inside, they're not getting enough. It's hard to get from the diet, so that's the one thing I supplement. So the only thing I actually recommend, I check the levels, and if they're low on D, I said, look, you're more susceptible to cancer and you're more susceptible to viruses. I tell everybody that vitamin D is probably what we were taught as vitamin C was, this immune system regulator. Vitamin D is the one that actually I think does a lot of that. And so that's the one I'll tell people, let's check. If you're really low, I would recommend supplementing. And everything else, I kind of put it on the, if you want to, fine. I don't feel like you have to. I think even the vitamin supplement for the eye is, that's a patented product. Those guys, the NIH patented that. And they drove that study through and they got 18% improvement in patients with mild forms of macular degeneration. It's a really weak study. Once I realized they had patented the thing and guys were making money off it, I realized, that was not a good thing. The other thing is, I do tell people that, if you're going to take the vitamin D, maybe consider doing the vitamin K2 because it does that in case if you're not eating beef, butter, and cheese, on a regular basis, it's hard to get the vitamin K2 in the diet. So I tell them, maybe do the D3, consider the K2 as an offset to the D that's going to bring in a lot of calcium. And so I'm not a big calcium fan. I always tell people, my patients, like calcium is like bringing sand to a beach. There's plenty of sand there. Don't worry about it. Get rid of the sugar in your diet. Consider taking the K2 because it activates that GLA matrix protein. Other than that, I used to be a huge supplementer. And I know you probably went through that at some time in your early career, protein powders and all that stuff. True or no? To some extent.
Yeah, I mean, I've always, athletics, I tried all the supplements and, it was kind of like, did you just waste your money? And you never really felt an objective benefit. It was always kind of, trying to convince yourself that there's a difference in really money.
Yeah, that's how I felt too. But I was, I tried it over and over. I tried different things. They come out with red beet juice and ribose was good for heart muscle. And, every time something came out, remember in the 70s, they tried to push that dynamic on the soy. And I was like, oh, soy is good. It's the Asian mystique, like they live longer and maybe soy, lots of soy, they do cultured soy, but basically I tried that. And I remember, I got a lot weaker over about 3 months. And finally, one of my best friends who'd never beat me in a race. And I was like, okay, that's enough. I went out and ate like 4 cheeseburgers that night.
So somebody's asking a little bit about maybe macular degeneration. Can diet have an impact on that, do you think, or is it causal? Or what's
no question about it. No question about it. Diet, basically, if your patients are prone to atherosclerosis and osteoporosis are prone to macular degeneration. So if you have either of those two disorders going on, you're doing something. You need to do something to improve that. And I'm going to recommend. I think there's dietary things that'll help, including, like I said, I love the carnivore diet. I think you and I know how much people have, harped on vitamin C, which you've shown is clearly unnecessary in people on a carnivore diet. Basically, you only need it if you're taking carbs.
Yeah, I would say that the carbohydrates increase our requirement, just like they probably do with magnesium. There's a lot of evidence that a lot of people are magnesium deficient. Is probably because we have a increased magnesium demand based on us by carbohydrate metabolism. And so I think that's one of the big issues. I've got somebody saying that the proposition for vaccination in Denmark ultimately did not pass. So that's good news to hear. So that's something to see. So what, like I said, what are you allowed to do at work right now? Then are you practicing? Are you at a clinic now? Or are you at a
clinic? I normally would see like maybe 25 or 30 patients. I'm seeing like 8 to 10, post-ops, a guy coming with a floater, the bleed, I might end up accidentally seeing somebody who didn't need to, really need to be seen because, the history was a little bit misleading, on the phone. And, like I said, he's not seeing well. It turned out he just needed maybe a new pair of glasses. So far, that hasn't happened. But basically, if people are complaining about visual complaints, we're not sure about the onset and what the nature of it might be, we're bringing them in. But if they're just routine follow-ups and stuff, we're trying to just push those off. And like I said, our clinic's probably cut to about, roughly a third. So I'll see like again this afternoon. I said I took off last week, and I had 30 something scheduled. I'll probably see about 10 or 12 in the afternoon.
What is, I'm not hearing a lot of cases in Texas. What's the situation in Texas? Because you've got that huge medical complex down there. California, New York, Washington State.
Okay, there's a lot of cases, but they're not getting diagnosed because nobody can get tested. One of my good friends is a dentist, and he went and got tested. 5 days later, still not the test back. Went back at the end of the second day, he realized that they were really not doing a good job, and they were really disorganized at the testing center. He got retested, and that was last Monday and last Wednesday. And so far, he hasn't heard back. So there's not going to be a lot of cases because there's a lack of awareness. And I think that goes to Ioannidis's point where, that stats guy is saying, like, we're not seeing a big number of cases right now, and they're waiting for the, the bell curve to kind of keep going up. And I think it's because first of all, there's a lack of awareness. Now there's a lack in a lot of places here, especially of inadequate testing. So it's hard to get tested. I mean, you literally have to show up. I talked to somebody in Miami. She went to the ER. They wouldn't test her because they said she wasn't sick enough. And literally she's, she called me and what should I do? And I was like, I can't help you. I go, if I write a prescription, they said, if I write a prescription based on your symptoms only, and I don't have awareness, I literally could be in trouble, lose my license. And apparently I might get arrested. I go, the insanity is getting crazy. So I want to help her. She's a friend. She's a patient here, but I can't. She's stuck in Miami. And I can't write, I can't, normally I would just, call a script in for her after hearing all that, document it in the chart, and move on. But I can't. It's crazy. So, but I think in general, one of the messages I think hope comes out of this is like, look, the Plaquenil really works. The hydroxychloroquine works. The thing about the azithromycin, the macrolide antibiotics, I've used those for a lot of years, like I said, for scarring. They do both increase the QT interval. So, I mean, you're going to get cured with just the Plaquenil. You don't need, let me say this. I think you don't need both. Obviously, there's no randomized trials right now. But from what I've seen, people are getting cured just on the Plaquenil.
Somebody was asking about the safety profile of Plaquenil or hydroxychloroquine in the context of retinitis pigmentosa due to a potential retinopathy side effect. What is your thought on that?
Okay, so in a short-term use over 5 days, 6 days, I see no problems. I think over the long term, it's toxic to the retinal pigment epithelial cells over the long term. So most of our patients who have toxicity have been people that we've been following for months or years. And typically it would be, it's the dosage, it's it's safe at about 6 milligrams per kilogram per day. So, you have to go by the weight of the patient. You might go a little bit lower, but personally, if chemically, you and I both know, if you get on a ventilator, get on ECMO, that's not good news. I pulled one study up and they put out of China, basically 5 of the 6 died within like 2 days. We don't want to let ourselves get to that level. And I think the toxicity and safety profile is so great over the short term. That's the reason why I think it's a no-brainer. If you had to take this for a year, I think, we probably might, maybe in a patient like that, run into some problems. But I don't see it, you'll need it probably for a week. Some people say 10 days. If you look at the studies, the patients clinically are better, but the studies that have come out so far show at day 6 that when you're on hydroxychloroquine, 25% of the patients still have PCR evidence of virus is still present. So in general, maybe there's a reason to do it for 10 days. I'm not sure, but clinically they're better, and usually like 1 or 2 days, they're a lot better.
Obviously there's no sort of treatment algorithms for this out there yet for this particular disease, but is there like a sort of, these people might need to get it and these people don't? Obviously, many people that get this virus are going to be asymptomatic or minimally symptomatic. Where do we draw a line where this guy needs treatment or not? Is it comorbidities? Is it age? Is it, if let's say you were Fauci and you're running the, I'm gonna use this as a how would you run the algorithm?
Yeah, and that's a great question actually. I think if I were Fauci, I'd say that the preclinical studies are very good. I think there's a lot of reasons why, in light of the fact that some of these people are going to end up on ventilation, they're going to end up in ECMO. I think that if patients come in and they clearly have evidence of bronchitis, fever, malaise, they clinically look that way, they ought to be treated. I mean, that's what I would recommend. And then clearly with the comorbidities, I think it makes it an easy choice. And then I think prophylaxis maybe for the frontline healthcare workers makes some sense. Maybe 1 tablet a day for people that are actually seeing these patients. If you're seeing 50 patients in the ER, you're going to get exposed right now. There's no question about it. I think it might make some sense. That's assuming that we have the supply chain side of things down, which I think will be pretty much there within a short period of time. So, if I were Fauci, I think I'd be more, and that's what I don't understand is why is he not a little more hey, this is the preclinical's really pretty good. It's a safe drug. It's been around 80 years. I think this is reasonable as we go forward. We've got to fix the supply chain side of this, and let's get the country back on our feet again. It makes a lot of sense. I don't get it. That's the part that if I were there, if somebody could get me up there with Trump or get you up there with Trump, I think, the thing we'd say is like, look, we've got a cure or we've got a great treatment. How about that? And it works. It apparently by everyone's studies, it works almost in the early stages extremely well. I've been talking to a doc in Atlanta too that has patients. They have like 4 patients on the ECMO. They've also, since they put them on the Plaquenil, all those guys are still alive. It's like day 5 or 6. Who knows what's going to happen? They already amputated a few toes on some of them because how that is. And in general, we'll see. But I think it's an easy choice. I think if the supply chain side of it is fixed, this is the drug of choice.
Yeah, somebody's just commenting on the I guess the mechanism of action for hydroxychloroquine. Is there any implication with the role of it being a zinc ionophore? Is that part of the?
Yeah, there's some people think that knock it so that spike protein, the glycoprotein that it binds to on the ACE2 receptor, can get disrupted. If you disrupt with the zinc part of that can be disrupted. But mainly, it's thought that it's acting on the outside of the cell and inside the cell. It's acting as an alkalinizer. So it's slightly alkalinizing the tissue, so it's harder to bind. But then once it gets into the endosome, they've shown in the studies, the preclinical studies, that the endosome, with preloading with hydroxychloroquine, the endosomal pH goes from like 4.5 to 6.5. So that's a huge, 100 times higher concentration of ions. So that's basically showing that it has a big effect, and that these viruses need a slightly acidic environment in order to do their work. So nucleic acid replication, it all gets backed up. So they go from the endosome. So this is like this virus is basically like it doesn't need the nucleus. For people who don't know, it's an RNA virus, a polymerase that basically doesn't need a nucleus to get in to get the DNA done. It can make its own proteins. It's got like a reverse transcriptase. It can make its own proteins and basically produce them once it gets into the cell and gets in the right environment, gets in the endosomes, and then it goes to the lysosomes. And of course, then it disrupts and destroys the cell, and you get this massive cytokine release of chemicals that basically destroys the lungs. So what this does, the chloroquine, the hydroxychloroquine, they get in and they create an environment that makes it really hard for these viruses to reproduce, and so they really can't do they can't make their viral proteins, they can't make their their nucleic acids like they need to, and so they basically that's it. They're just unravel more or less. I usually talk to people like these viruses in a sense are like a shoelace all tied up in a nice bow, and when you get them to break down, it's like a shoelace, but there's no bow. It's not folded properly anymore, and that's kind of what happens to them in this environment.
Are we seeing, because we've got this, some people say that maybe hydroxychloroquine from a drug treatment standpoint is a potential solution. And then there's, I can't remember the name of the antiviral medication.
Azithromycin, the macrolide, like azithromycin, chlorothromycin. I think.
Yeah, but I mean, there's an antiviral medication, that's being touted as well.
Remdesivir.
Okay, right, and that obviously those things tend to be. We probably don't have long-term toxicity and side effect profiles. It's obviously going to be much more expensive. And so what seems to be? Are people using both? Or is there one thing that's winning versus the other thing?
So what's coming out now is that, like, because of that French study, everyone's doing the Plaquenil hydroxychloroquine mixed in with the azithromycin. The chlorothromycin, that's Biaxin, erythromycin, they're all macrolides. They downregulate, they're immunomodulatory, and so in a sense they're probably decreasing the inflammation that's occurring in the lungs when this virus attacks. And the Plaquenil is actually probably has a lot more antiviral effects. I think in general, the combo may end up being better, but the combo, they both prolong the QT interval. So I'm not a cardiologist. It'd be nice to have somebody in cardiology weigh in on that. As we know, a Z-Pack, nobody, you don't hear people having arrhythmias from a Z-Pack. Neither do you hear it with, I've never seen a patient that I knowingly have had in my practice who had this with Plaquenil, prolonged QT interval, and they had some issue with an arrhythmia. I've never seen it. Doesn't mean it's never happened. I just never seen it. But bottom line, I think when you combine the two, there may be an issue there. And so I think right now, this is where this is going, because it's that French study has taken everybody by storm. And I'm just recommending to if somebody calls me, I'd say, just do the Plaquenil. It's super safe. You don't have to worry about the drug interaction. And I'm watching, I've seen it. I've seen, not only have I seen it myself, but other people that I've talked to have told me they've had good results. I have not known a single person who was caught early on in the disease process who was positively tested who didn't respond to Plaquenil.
What's the situation there for healthcare providers in the medical complex or wherever you're at? Do you guys have access to testing? Can you test yourself? Is it mandatory, non-mandatory? What's the deal?
Yeah. So, great question. That's what I'm saying. Even us, is like I said, we're going into the testing centers and we're not getting the results back. So let me say here, it's been a problem. I don't know about other places, but in Houston, we've had lack of testing has been a big deal. So our numbers are a lot lower than Louisiana's. Louisiana's gone over 100 cases. We're like in Houston's like 30 something cases. But I think it's mostly because of lack of testing. I don't imagine that it's not worse than that.
I know this is purely speculative, but people are talking about what is the mortality rate on this disease, and some people are saying it's as high as 3%, which would be like Spanish flu numbers. Other people are saying because we don't know who's been infected, we don't know what the minimally symptomatic cases are. It could be much less than that. Is that starting to sort of get more clarity on that, or is that still widely unknown?
Widely unknown, and like that's been weighed in on though, which you just said, and by various measures, Ioannidis, who he's a genius with stats, basically said it's somewhere close to 1% or maybe like 0.3% is what he said. And I'd hate to try to argue with him on a stats basis, but he's weighed in on it, and he predicts it at its worst case to be under 1%.
Yeah. Which would still mean a fair number of people would succumb to that. So it's not it's still worse than the seasonal flu by quite a measure. But I'm trying to think. Right now we've got this full on lock everybody down mentality. Is that does it make more sense to have a more measured approach and a targeted approach where we isolate those that are have comorbidities, or is it because people are still going to the grocery store, to the gas station, plumbers are still coming to the homes, does it make a difference, or should we just be putting all our resources into identifying those people at risk, prophylaxing them any way we can, getting them the care, the meds, and the isolation they need, or does this need to be every single person in the world hiding under their bed?
Yeah, I have to say, I think what you just said at the end there is what sounds reasonable to me, that we identify those at risk, we identify and treat and prophylax people who are high comorbidities, but potentially, I think that makes a lot more sense than shutting down the entire world. It just seems epically overblown. And for that reason, for two reasons. One, we actually have a treatment that's safe and appears to be very effective. And I think without that, this conversation would be maybe more tempered, right? We'd have to temper our conversation with knowing that we don't actually have any way to treat them. We have a treatment. That's why this is epically overblown in my mind, because we have something available and it's working. And I think to hold down the whole world doesn't make a lot of sense.
And somebody made a comment that they're saying that in the UK, the people that were in critical care did not have comorbidities. I'm not sure if that's where that came from, but I mean, it does seem to be that the majority of the people affected are elderly and comorbidities in most places. Is that not the case that you've seen or heard of?
Yeah, no. So I talked to people that are in Italy, and they said basically most of the people dying there are old, elderly. But as you know, you got healthcare workers on the front lines. You know, you get into bigger viral load. So younger people, there are some younger people. You know, they got probably a bigger load. They're dying too because I think in general, like I said, they weren't prophylaxis. They didn't get prophylaxis. They didn't get early treatment. They got to the point where they were basically, you know, almost to the pneumonia point instead of the early bronchitis stage. They got to that point where they were overwhelmed with the virus. They were overwhelmed with the cytokine production. And at that point, you know, and maybe there are some, you know, as you and I know, somebody in their 30s doesn't mean there's not some underlying, you know, issue going on where they're not as healthy as they appear, so yeah, I think people in their 30s and 40s, yeah, they're going to pass away. Like I talked to a newscaster who called me on this, and she was really upset about what I was saying. And she had a sound engineer that passed away. And I said, look, my condolences. I'm really sorry. I feel badly. I said, but at the same time, this is clear cut in my mind. We've got a treatable disorder with a safe and effective safety profile and it's effective, and a drug that's usually readily available. And I think that to go and hide in our houses like scared rabbits doesn't make a lot of sense to me. I just don't think I think it's overblown. That's my own feeling. That's my opinion, and I feel strongly about it because like I said, I've talked to somebody yesterday. I said, I put this out there. I'm sort of in a sense putting my career on the line. Somebody might, if I turn out to be wrong, somebody will come out and said, you spread bad news. I said there was a fire, you know, in a theater and people died, you know, so in a sense that I would be subject to that, I would assume. But I feel very comfortable telling people, look, this drug really works. It's safe and effective. This is the smart way to go. Anything else is, in a sense, by going and hiding in our houses, I consider that draconian, and I think it's overblown.
Yeah, I mean, it's, you know, it's kind of a lose-lose proposition because, you know, if the virus peters out, you know, and gets better, which it may or may not, we don't know that. You know, some people think it's not going to get better with the weather. Some people think it will. You know, there does seem to be less incidence of severe cases in warmer climates, it seems. That's stats I've seen, which would sort of point to inactivation by heat and humidity. But there's people that are dissenting on that, saying that that's not the case, and it didn't happen with SARS that way, and it didn't happen with MERS that way because of, you know, MERS came out in the Middle East where it's 110 degrees, and so we don't really know the answer to that. But eventually it will go away. It'll calm down, and whether it's herd immunity or temperature, people are going to say, well, it's because we locked everybody down. And so it's kind of a, you know, you'll never know the answer to that. So it's,
yeah, and so everybody will be right. So in a sense, I think the herd immunity is definitely, you know, is going to help obviously over the long run. And I think that's happening right now. I think a lot of people are infected at low levels, and it's the people, like I said, the statistical analysis helps at some point because we'll realize that a lot of people that one person I was talking to had come back from China in January, and he clearly was infected. He didn't know it though. He did, you know, he was unaware. He just said he had worse bronchitis of, you know, that he had. And, you know, he's like almost 70 years old, he's a friend of mine. And a couple of people in his family got it, and the younger ones did pretty well. And now he looks back and he clearly had probably, you know, this COVID-19. So, you know, I think there is going to be that herd immunity that's going to help out. Obviously, these measures, I won't say that, clearly I think the measures are helpful if that's the goal. They're helpful in this one instance. But what about the loss of people's, you know, they're going to lose their jobs, they're going to lose their houses, they're going to, you know, they're going to lose, they can't pay their car payments. What about all the fallout and all the things from that occur when you create this complete lockdown? You basically ruin people's lives. Small businesses, how are they going to get up and running again? You know, a lot of people's lives will be destroyed if this thing goes on for very long. The treatment is going to be worse than the disease. I think that's what we're looking at now, is as this thing drags out for very long, that's what we're going to be faced with. We had an effective, safe treatment, and we decided not to do it, and then we basically bankrupted, you know, 1/3 of the country.
Yeah, I mean that's obviously a concern, and that's a concern on a lot of people's mind. There's people I know. I'm sure a lot of people with small businesses that are that just are they can't afford a month out of with no income. They'll go under, and we'll see lots of that in many places. We'll see that. So the knock-on effects of this, just not the health, but the economic, which will also subsequently lead to mental health issues and other things we've talked about that are they're going to go on for quite some time. Somebody's saying, are you seeing any evidence of, because somebody commented on Ted Naiman saying that hydroxychloroquine is very difficult to get. Are we seeing a run on that where that medication is?
Definitely are. I mean, it's they've definitely had a run on it. That's true. And I think as people became aware of it, of course, they started buying, this 90-day supplies. You could get last week here in Texas, you could get a 90-day supply at Kroger for $12. Now, in order to get it, you can get about a 12-day supply for $500. So it's quite a bit different. Scarcity, it's the law of supply and demand pretty quickly. Yeah, there is. And I think but that's where the efforts need to be. The efforts need to be on getting the drug into the right people's hands, the docs and the pharmacists, so that they can dispense it. Like I said, give prophylaxis to those healthcare workers. That's what I would recommend. They're on the front lines. They're going to get exposed, and they're not just going to get exposed once in a day. They're going to get exposed multiple times. The viral load is going to be higher. To those people with comorbidities, make sure, at the very earliest signs and symptoms, they get treated. We don't need to let them get sick. And for the younger people, I honestly have to say, until we know, I would personally, people come into your office, if they're not feeling well and the flu's going around, you might give them Tamiflu, even though, like, I'll give you an example of this. They did autopsies on Tamiflu patients, on flu patients, I don't know, 2017, maybe 50 patients. And they found that 17% of them had active flu virus in the lungs, that they could, PCR revealed. But 47% had some type of virus. So in a sense, this disorder that we're seeing, we may be guessing wrong sometimes, but interestingly, chloroquine and hydroxychloroquine have activity against the flu virus also. But bottom line, we may guess wrong in some cases. As you know, that can happen. That's part of the art of medicine, right? Is to try to figure out the patient that's sitting in front of you without all this extensive testing a lot of times. But assuming right now with what we have faced, I think it makes a lot of sense to get that drug in the pharmacist's hands, the doctor's hands, dispense it to the people on the front lines as a prophylaxis, and then give it to those people with comorbidities at the earliest signs of disease. And don't hesitate on the younger patients, because there's no sense in letting them get really sick.
How are you guys doing with PPE? Are you guys, is that you guys running out over there as far as personal protective equipment?
Yes, but we got these. This is not going to prevent. I can blow through this, so it looks good. So, yeah, we're running out, and I'm okay with that. I mean, it's up to me to decide what I'm going to do about that. As you know, we've been through a lot of other things. I remember going through the AIDS epidemic. I'm 61, so I remember just being scared. We didn't know what it caused by, and every time they were coughing, I was like, I wonder if I'm going to catch it. And I don't mean this in any disrespect or anything, but I was stressed out. Not knowing at the time what the transmission mode was, and it was scary. I remember being scared, and the young people were dying, and and it's scary being in an epidemic and being a healthcare provider. And so for the most part, yeah, you want that protective equipment. And that's a big issue. And I think, so I get some of the measures that they're pulling here. What they're saying to us is we're being selfish in a sense if we treat regular people who are healthy we're wasting things that could better off go to the hospitals. So we're going out of our way not to use stuff that would be considered protective equipment at the hospitals. We're using these. Now, some people may have their own stash of N95. That's fine. We're letting them use it. But me personally, I'm just using this.
What is the Texas State Medical Board or some of the organizations, medical organizations, are they coming out with some
stronger and stronger, basically saying today, like I told you, that you better be careful you're going to be reported and you're going to lose your license, and you may even go to jail if you do an unnecessary surgery. I mean, I just saw that today, and I was like, I just told him, I said, tell that lady you got to cancel. I mean, I'm not getting taking a chance. I don't want to end up in jail. I mean, it's crazy.
And they're saying unnecessary surgery is, life, limb, urgent, emergent, are considered okay, and then anything else.
Yeah, exactly. But if you have an infected lacrimal tear duct, I mean, it's really swollen in the face. The old days, before antibiotics, probably 20% of those patients died. We can give her antibiotics and kind of calm it down. And so that's what I'm going to do. I was going to give her antibiotics. Hopefully she calms down. If she gets really bad, of course I'm going to go. But if I can calm it down, I'm just going to try to calm it down.
Yeah, so that's, I mean, that to me, just, like I said, it does seem like we're a little bit of, maybe a little bit of an overreaction here. I mean, I can see maybe a cataract or something like that we're,
yeah,
you don't hear right now, but what has been, so you said because at the beginning, I didn't follow up on this, you said you had seen a couple patients,
yep,
given them Plaquenil. Were these COVID-19 patients that you actually treated?
So I have some presumed ones that we treated last week, but 4 that are actually known COVID, and they all responded really, really well. I'll send you a text from one of them later, but kind of like you get those notes, and they were just so thankful, and yeah, none of them were in the hospital. But I've actually, as I said, I actually been trying to encourage the other docs to use the Plaquenil for the last like 10, 12 days actually. So I got on it and then realized it, saw it, and recognized that it would be effective. And I've been trying to get everybody to use it that I know. And a lot of them are listening. So I feel like I've had some impact, helpful, so.
Well, I'll tell you what, Dr. Urso, thanks for coming on, and we've taken up an hour of your time. I really want to appreciate it. I know everybody here is I think appreciative. It's controversial, and there's obviously people that feel strongly both ways about how much isolation do we need to do. I think the answer is we just we're not going to know, and we certainly know that isolating and shutting down business will definitely, unquestionably, have an economic damaging effect. That's for sure. Will it definitely change the outcome of this pandemic? I think that's unknown. Is there a way to
change the bell curve, maybe?
Yeah. So we don't know if we flatten the curve or not. Will it ultimately result in less or more overrunning of the healthcare system? It's unknown, I think. And I mean,
Lisa now. Hi, Lisa.
Yeah. Yeah, I'll connect you guys after this.
All right.
The thing is, I mean, I wonder, do you see that there's going to be lasting, permanent changes on the way we do things as a society, as a healthcare system, based on this newest pandemic? Do you think this is going to have a big impact 5 years from now, or what do you think?
I've never seen it before. So, it's a lot of years in medicine, and I've never seen anything like this. So we've been through hurricanes. I was through a flood where the hospital was shut down and was flooded with 30 feet of water, and we had patients in ICU. I was bagging patients, trying to get them up to the roof. We ran out of respirators. We had to bag them because we didn't have any more. That was a panic mode thing that happened here, 20 years ago. It was incredibly intense and horrible, but it only lasted for a very short while. But it was a couple of days where, that was the worst thing I've ever seen in medicine was, having to choose who am I going to bag. We had at the ICU beds at Hermann, there's probably 80 of them, 100. There's only so much. We were getting exhausted. There's no relief inside. People couldn't get to the hospital because I waded to the hospital. I only lived like a quarter mile away, so I waded my way over through about 3 feet of water. Got there and helped, and I mean, it was horrible. So, the lasting effects of that, we made changes and we implemented changes down here based on those things. So I think as we go forward, we'll see the same thing where, there may be some more measures that'll be, in a sense, put in place to help us through a pandemic like this, and maybe some legislation, maybe that'll come into place that'll sort of say, here's what's going to happen if we declare a pandemic and we have to lock down. Here's what we're going to do, that kind of thing. So I think some of that stuff may happen.
Yeah, I mean, I saw like when Hurricane Katrina came through, in that Houston, New Orleans area, and this caused so much devastation. There was those changes that were made. I think these viral epidemics and pandemics are going to continue. Just like we see everything's coming out of China, these population densities. I think that's probably the main reason we're seeing this occurring, and I think it's going to continue to occur in more frequency. And we have to have a better solution than shut down the entire world every time it happens.
Yeah, the exotic meat market. Some people were talking about that, and I think that's. I don't know. I don't know the answer to that. The exotic meat markets are sort of I almost call seedy underground stuff and not well regulated probably. And I think that a lot of the stuff jumped from those bats and other animals in that kind of a market. So it's going to happen again, right? You're right. There's no way this is just one pandemic. It's going to happen again, obviously. In the next 20 years, we'll probably have 3 or 4 more.
Yeah. All right. Well, thank you so much. We're going to let you go. I'm going to shut down the meeting, guys. Richard, thanks so much for finally getting a chat with you, and I will connect you and Dr. Wiedemann by email here shortly afterwards. You guys have a great day. Thanks for attending, and I'll see many of you guys tomorrow. Take care.